Okay, I think we'll go ahead and get started. Welcome, everyone. My name is Rebecca Ganan, and I'm at McMaster University, and it's my pleasure to be the moderator for this session. I just want to remind everyone about the process for the questions. So the questions will be answered at the end of the presentation. We will call on each site one at a time, and you can also send your questions through the chat box in WebEx, and we can read them on your behalf. And we are really pleased to welcome Kaelan Moat today. He's the scientific lead at Health Systems Evidence and Learning at the McMaster Health Forum. He's an assistant professor in McMaster's Department of Clinical Epidemiology and Biostatistics and a member of the Center for Health Economics and Policy Analysis. He holds a Bachelor of Health Sciences from Western University and a Master's from the London School of Economics, as well as a PhD in Health Policy from McMaster University. I just want to also let you know John Lavis is unfortunately not able to join us today. He is traveling and his internet connection was really not going to support this. We made some best efforts, but it just didn't work out today, unfortunately. And we just want to remind everyone to please keep your microphones on mute. And then when we have questions, or when you have questions, you can just unmute yourself for that time. I did say there'll be questions at the end, but in fact, Kaelan will be having a couple of opportunities to pause for questions throughout his presentation, and I will call on people at that time as well. So welcome, Kaelan. We're really pleased to have you here and to learn from you today.
So just checking that everyone can hear me. If they can, put a 1 in the chat box, and that would be great. So just confirm everyone can hear me through the microphone. Yeah, great. So at least somebody can. So hopefully we're speaking great. So 2 sites can hear. As Rebecca mentioned, John sends his regrets. I spoke with him briefly on the phone this morning, and that was even the challenge. The connection just isn't good enough to have him phone in remotely and ensure that we're able to hear everything that he has to say. The good news is that I've been working with him for 6 years, and a lot of people have told me that I end up sounding like him a lot. So, and that just comes with the territory of learning from somebody. But the whole point of today's session really is to share what we're starting to see through all the years of experience doing this stuff with policymakers at the system level, what we consider now to be somewhat of a magic combination of buckets of things that we consider when we're working through KT problems. So the title of this talk is Evidence and Insight in Context. We're really going to focus today on what we know about where to draw evidence and how that evidence relates to policy questions, the types of additional insights you need to have when you're working with that evidence, and how to put this all together in context to support evidence-informed policymaking. So this. Maybe if you click on the, yeah. Great, so can everyone see the advanced slide? And number 1 would be great if you can. Yeah, great, so at least someone can. So the learning objectives for the talk are really, as I just mentioned, to understand the key sources of what we call pre-appraised research evidence and how these sources and types of evidence you find there align with key policy questions, to appreciate how we gain insights through things like deliberative dialogues, both with stakeholders and citizens, that help us put the evidence alongside other constraints and factors that facilitate policymaking. And finally, to recognize that we all need a solid understanding of both the health and political system context to make all this work. As I just mentioned, so many things matter in shaping a policy process. Without really understanding that political and health system context, we're not going to get very far, regardless of how blue in the face we get with our efforts to support evidence in the policy process. So again, I'm losing the ability to advance. I got it back. I think you just need to be clicking on it. So in terms of sources of pre-appraised, synthesized research evidence, I'm not going to get into the discussion about evidence hierarchies. I think everyone on this session probably knows very well those things. What I want to point folks towards is that there are different sources of pre-appraised, high-quality systematic reviews depending on the type of question you have. So if you're really interested in trying to understand which drugs, technologies, programs, services at the clinical level you might want to pay for example, at the policy level, you'd be looking to a place like the Access database run by the Health Information Research Unit at McMaster. If you're interested in those public health questions, you might be looking at health evidence, so the database run by Maureen Dobbins' group here at McMaster, which tells you things like which population-based programs you might want to support. And finally, if you're interested in questions about how to arrange ourselves at the level of health systems governance, financial delivery arrangements, where would you look? You'd look to health systems evidence, and that helps us figure out what the right way to get the right programs, services, and drugs to those who need. So different levels of decision-making, different sources of pre-appraised evidence that we tend to point folks towards specifically to get the best evidence of that. So with those three sources in mind, it would be great if everyone at their own sites could get a sense from the group that they have of how many of these sources have you signed up for an evidence service from. So is it 0, 1, 2, or 3? I'll give everyone about 2 or 3 minutes now to answer how many of these evidence services have you signed up for. I got a 0 here at Mac. So 2 zeros and a 2 at Mac. And it just so happens, and that's a little bit embarrassing because all of these sources are actually located at McMasters, so we need to do a better job of promoting things internally. Okay, so the whole purpose of this really is to just reassure everyone that you don't have to go to these sources and run searches all the time. If you have topics you're particularly interested in, each of them provide you with an opportunity to sign up for an evidence service that prompts you every month in your inbox with the best available new evidence that's coming out. So you can do that, and I would suggest you do if you want to save yourself some time. And that's what we present to policymakers as well. If you want to save yourself some time, you can go to these sources, sign up for an email service, always get the latest stuff about the topic you're interested in, whether it be health workforce planning, sustainability, or mental health promotion. You can go there and get evidence services about these topics. We also know that it's not just one type of research evidence that we need to inform policy processes. The policy process tends to be broken up into a number of different stages. Here is a very simple breakdown across 3 of those stages. One is agenda setting, the second is policy development, and the third is implementation of policy. And you'll see that within each of those stages of the policy process, there are different types of questions that need to be asked. And different types of research that help answer those questions. It's not just about reviews of effects. We've known this for some time. Increasingly, we're seeing people publish papers mapping this out. The reality is that if you're trying to prioritize problems to address in the policy process, you're really going to be focused on things like making comparisons between your own jurisdiction and other jurisdictions, progress over time, those types of things that help you determine whether there is a problem or not, and if so, how big is it? For this type of question, you'd be looking for sources like administrative database studies or community surveys and reviews of those types of studies. So not RCTs, not qualitative work, different type of evidence altogether. Also within problem definition and agenda setting, you might be looking at framing the problem in a different way to motivate different groups to act. So if you're targeted at citizens, for example, you might want to look for a qualitative study about how citizens view a particular pathway to reform. So again, you're looking at a different type of evidence to help you with that framing component. When you're at the options development stage to try and address the problem, lots of different types of questions. So the one that most people tend to jump to first is, what are the benefits with different interventions? So are we seeing that one intervention works, another one doesn't? And here you'd be looking for systematic reviews of effectiveness studies such as RCTs. You also want to know when you're trying to work up policy options what potential harms there might be. And sometimes the reviews of effects have these harms worked out. Oftentimes they don't, so you might also be looking at reviews of observational studies to see whether or not there are any associations between a particular intervention and particular harms. Policymakers in the options workup stage often want to know about cost and cost effectiveness. So here you'd be looking at cost effectiveness studies, and ideally these would be local cost effectiveness studies. We know that things like inflation and a lot of economic factors influence whether or not costs are applicable across settings. So you first look for local cost effectiveness studies. Once you've worked through all that, you might also want to know if you're going to go forward with a particular intervention that is effective, cost-effective, has no harms. You might also want to know whether or not you need to adapt it for your own particular setting. And to do this, you might look for research evidence, qualitative research evidence, and reviews of qualitative studies that are process evaluations that tell you what the key components of implementing a particular intervention were in a setting, so you can flag those for yourself and determine whether or not they can stay the same or whether they need to change in your own setting. And of course, you want to know whether or not there's going to be acceptability of an intervention, whether or not particular stakeholder groups or actors in the system are going to push back. And here you can look to research evidence as well, different types. So you look for qualitative research evidence and specifically acceptability studies. So just within the problem and options workup, you can see that there's so many different types of research evidence that can inform different types of questions at each of those stages, and all of them can be drawn from different sources. When you're on to implementation, it becomes about barriers and facilitators. So are there particular barriers we need to pay attention to? And here you'd look to things like qualitative studies. Again, acceptability studies might be helpful there, and reviews of acceptability studies. And then once you decide that you have a barrier that needs to be addressed, you might come up with an option to address that barrier, and then you're going back into determining whether there's benefits, harms, what are the costs and cost effectiveness. So for example, if you know that one of the barriers is going to be uptake in clinical settings of a particular practice guideline, you might look to reviews about how to overcome that. You see that audit and feedback has particular benefits in particular situations. You might also want to know about if there's any harm sought in feedback. The costs, oftentimes prohibitively high to do something like audit and feedback compared to simple reminders. But it just goes to show you that there are many different questions in implementation that you ask as well, and different types of evidence that can inform these questions. So this is mostly great for policy folks and stakeholders working through policy issues, but citizens also might want to know about what the evidence says as well for their own uses, as well as to be great advocates for change or to push forward change in their own ways in community settings, or even when they're meeting with their healthcare providers. Unfortunately, it's not as though we can point citizens towards resources like access, health evidence, and health systems evidence. They were developed first and foremost for clinicians, policymakers, and other researchers. So it's really difficult to sell that off as a citizen-friendly resource. So what has been done at McMasters, those three groups that developed those three different databases came together and said, let's do something with funding from the Large Optimal Aging Initiative to put forward the best available evidence about optimal aging for citizens. And they came up with 4 product types that are attempting to overcome some of the main frustrations that exist among citizens that constantly come up. So for example, evidence really isn't easy to understand and use. Well, we all know that here. Policymakers may mean one thing, citizens mean something very specific. They don't necessarily know what the key messages they should be taking away from research are and how they can act on them if they can be acted on. So the McMaster Optimal Aging Portal puts forward evidence summaries that provide key messages that are ready to be acted on. Another frustration that comes up quite a bit is that there's just so much out there on the internet. So what do we do when we're Googling about dementia? How do we know we can trust the source? So what the McMaster Optimal Aging Portal also did was provide evaluations of online resources that tell citizens and flag for them whether or not they can trust those sources based on if they're evidence-based, and a number of other factors. A third big frustration that comes up quite a bit is that, yeah, key messages from one study are great, but what does that mean for an entire topic? So if my husband has just been diagnosed with early onset Alzheimer's, there are many different things I need to consider, including how he's going to fare with activities of daily living, whether he should be exercising. So it's not just about the key messages from a single review that you'd find in an evidence summary. It's about taking all of that into context on a particular topic. So the McMaster Optimal Aging Portal also provides blog posts which take a whole topic on, provide key messages from a number of reviews, also integrate things like expert opinion with clinical experience and patient experience. And finally, and this is something I think we all deal with when we read the newspaper, there's just so many messages coming out. We don't know what to trust in the news as well. Mixed messages, one day red wine is good for you, the next day it's bad for you. So what do you do? So the McMaster Optimal Aging Portal set up what's called the Hitting the Headlines Twitter service. And people who follow it will see that every day there are new headlines about optimal aging that we tweet about. And then we follow that up directly with a tweet that says directly if it aligns with the evidence or not. So that's another way to get at this. So 3 sources of evidence that I showed you, different types of questions that you might ask in policy development processes for those different types of resources, drawing on evidence from those types of sources. When we look at the level of citizens, they also need evidence and want evidence. We need to approach it slightly differently, and that's what the McMaster Optimal Aging Portal has tried to do. So just out of curiosity, does anyone on the call, and again, show of numbers at each site, how many in your group have searched the portal and its different types of products? Big zeros everywhere. So another follow-up question is,
we've got a better show in McMaster this time, Kaelan.
So we have 3 at McMaster, great. So someone at Dow, someone at CPAC, great. So interesting to know, and now I'm starting to feel like this is more of a promotional opportunity than anything else, but it's a great resource, you know, and I'm just saying that as a contributor, but also as someone who's now been involved for 3 years and actually worked with older adults across Ontario and asked them whether or not they find this as a useful tool, and almost invariably the answer is yes. Still things to improve upon, of course, but you know, at least we're out there trying to get evidence in the hands of people who want it, and you know, trying to put them towards sources of best evidence, like access, like health evidence, like health systems evidence, in one portal rather than having them go off to Dr. Oz. So that's kind of the impetus behind that. So another thing that's coming out now is developing different types of syntheses to support decision making, and we're seeing many different types of syntheses coming out. So of course, systematic reviews focus on specific policy relevant questions, something we're seeing quite a bit these days. There's more than 5,600 sitting in health systems evidence that I know of, many other policy relevant reviews in other sources, but at the system level, we're almost at 6,000. So people are increasingly asking targeted questions that are policy and systems relevant and putting them into the public domain. We are also seeing an increase in the use of what are described as rapid response services. So we have one here at McMaster Health Forum. I know of colleagues in Burkina Faso that have one, Uganda, and a number of others across the world. And these are just to respond in real time to policymakers' requests for evidence in 3, 10, 30 business days, and just bringing together all that is out there in that time frame and can be brought together in that time frame in a nice package for people to wade through, and hopefully in a user-friendly format. And finally, evidence briefs, which we do a lot here at the McMaster Health Forum. I think we've done 45 of them now, and these are a little bit longer, not 3, 10, 30 business days, usually months, probably 3 or 4 months on average to develop one of these things, with the key features of describing context, problem, options, implementation, using a systematic approach to do this, so engaging key informants to frame things in the right way, looking at the sources I've just discussed of pre-appraised evidence to make sure we're getting all of the evidence, focusing on systematic reviews, and then combining that with local data and insights as well. Not concluding with recommendations, because that would require us as the authors to impose our own particular values and assessments on the evidence, rather than just presenting it as an unbiased way as possible, just describing what the evidence says about particular problem, options, and implementation considerations, including a reference list for those who'd like to read more, employing graded entry format. So we are now using a 1-page of key messages, 25-page report, where a lot of other groups are using 1-325 format, and subjecting it to a merit review to make sure we're getting the framing right from a policy relevance standpoint, engaging a researcher to make sure we've done our best in being methodologically rigorous, as well as others who might be able to weigh in on it. So usually one policymaker, one stakeholder from an organization that isn't government, and one researcher weighs in as a merit reviewer. So we are increasingly seeing these being used as an input into stakeholder dialogues around the world, or into citizen panels. Every time we develop a brief at the forum, we do use it as an input into a stakeholder dialogue, which leads us nicely into the next part of the talk. So I think once you go to chat, it actually goes back. Yep, so the next part of where are we getting insights? So how do we get insights that are also important for policymaking to sit alongside what the research evidence says. So at the forum, we do this through two primary ways. One is through the stakeholder dialogues, and one is through the citizen panels. We're seeing these being used around the world as well. A lot of key features are common around the world. The idea really being here that if you do a good job putting the evidence together in a brief, that's not enough. You also need to gain insights about things like institutional constraints that exist in the political system, interest group pressure, which is also very important in kind of determining the trajectory of a policy process. Values, so whether different stakeholders have different values about a particular issue, whether efficiency trumps things like patient-centeredness, like there's lots of different things that can come into play that affect the whole trajectory of the policy process. And again, common features that we're seeing around the world and things that we hold ourselves to being as consistent as possible with are ensuring that it's always addressing a high priority issue that's happening in the system. And so it always aligns with the brief that we prepare, which is also focused on a high priority issue. We provide opportunities to discuss not only the context and problems, but also options to address the problem, implementation considerations, and most importantly, who in the room could do what differently to help us move forward. So always key features of the dialogues. We also try and aim for fair representation among stakeholders and policymakers. The idea being that it's not just people in the room that are going to make decisions, it's also people that might be affected by those decisions to get their insights as well. Just as important in the policy process as someone who's actually at the end of the day making the final decision. Engaging a facilitator, hugely important. Someone who has experience or has been coached by someone with experience to make sure they're getting the tone of the day right, that things go smoothly, that enough time is set aside for each of the deliberations. And really important is this idea of adhering to a Chatham House rule. So the Chatham House rule essentially just means that nothing in the room that is said can be attributed to an individual or organization. So this allows people to feel more comfortable, to really get at what their values underpinning their positions are, what barriers they might think exist. Not to say we don't prepare a dialogue summary that outlines the key themes that came out of the day, but the idea is that it shouldn't be allocated to any one organization or individual in terms of responsibility for saying something or pushing the discussion forward in one way or another. And finally, not aiming for consensus. So the idea behind not aiming for consensus really is that if you get a lot of stakeholders and policymakers in the room, it's very difficult for one individual on behalf of an entire organization to sign off on something. So we don't put that expectation out there on the table when we convene our dialogues. Not to say that consensus can't happen naturally, and it sometimes does, but it's just not something that we fit into our features as something we push for. So as I mentioned, 45 now done at the forum. So 45 briefs informing 45 different dialogues, almost 800 people surveyed in each of those camps, high response rates because we're literally waiting for people at the door when they arrive to finish their evaluations and make sure they don't leave without filling out the evaluations. Although about 16% of the briefs and 19% on the dialogues have snuck out the door without letting us ask them for their opinions. The big messages here really are that we're seeing across all of these dialogues really high ratings, an appreciation for the approach. So almost invariably, maybe one outlier here or there, high ratings. People like these things, and people like to be a part of the process. That being said, there are some features that are coming out time and time again as being rated as the lowest. So for briefs, it's not including recommendations, and for dialogues, it's not aiming for consensus. So the two things that we have very particular reasons for not doing are also the things that people, find difficult to swallow when we say, oh, we're not including with recommendations. So on our end, I think, we've come to the realization we just need to do a better job of communicating our rationale for that, and perhaps that will get us a little bit higher on those. In terms of measuring things like theory of planned behavior, so are these actually having an influence on whether or not people are using evidence, which is the big, the holy grail of all of this work. A lot of people leaving the dialogues have strong intentions to act on the evidence that was prepared in the brief and the types of insights that were gained at the dialogue. Unfortunately, they often find that it's outside of their control. So the lowest rated attribute is often whether or not they have perceived to have behavioral control to act on the evidence. So can people hear me okay? We got a message from Dal that they can't, but now I'm holding the mic. So can you hear me better now? Great. So that leads well to the next question, because I know the chat room is working. It would be great if everyone could weigh in from their groups. How many have ever read an evidence brief? It could be one prepared by the forum or one that's prepared outside the forum. And have you ever read a dialogue summary? So first, let's see if everyone has read. It looks like a lot of yes. 4 to 4 here at the forum. McMaster, great. And how about a dialogue summary? So these are a summary of the key insights that came out of the day. Yes, for brief, no for dialogue. So interesting. So these products and the outputs, well, we call them outputs, they're meant to be taken together, and the reason for that is, as I discussed at the beginning of this talk, really we're trying to get evidence paired up with insights. So by putting into the public domain the evidence brief alongside the dialogue summary, that's our approach to getting at that. And we also do the same thing for citizen panels. So we prepare a panel summary which gets at the values and beliefs of citizens on the same topic. So you can hold up the evidence brief, see what the evidence says, and then read the dialogue summary or the panel summary right afterwards to see, well, what do stakeholders think about this topic and what do citizens think about the topic? So trying to pair evidence and insights. So again, citizen panel is very similar to our stakeholder dialogues. The difference is we bring together ethnoculturally and socioeconomically diverse groups of citizens, provide them with a user-friendly version of the evidence brief. We're doing our best to get them pared down, but it's really difficult to simplify something like health workforce planning, especially when there's so much technical jargon associated with it. And we give them the same types of facilitation to work through problem options, implementation considerations, and ask them for their views and opinions about how we should move forward on this topic, given what the evidence says and given what they know about the issues. So we've now done 20 briefs. So these are sometimes aligned exactly with the evidence briefs that I mentioned. Sometimes they're different topics altogether if we're only doing a panel, but increasingly we're doing these things together. And we've done 32 panels. So the reason the panels are higher is because we sometimes have more than one panel for a particular topic if we want to get insights from different geographic regions. So we've done one across Canada where we had a panel in the West, the Maritimes, as well as in Ontario. More recently, we've done one across different regions in Ontario itself. So for workforce planning, I was up in Sudbury, went to Ottawa, and then we also held a panel in Hamilton. So that's why the number of panels is higher. So we're trying to get a little bit more diversity in the types of feedback we get. Over 400 participants and citizens now surveyed about the briefs as well as the panels. And again, we're seeing, appreciation for the approach, high ratings overall, and really high ratings with the panel itself. So citizens really seem to like the fact that we're providing them with an opportunity to come together for a day and discuss these issues that are really high on the policy agenda. It's different than just simply stopping them in the street and polling them or coming together for an hour focus group. It really is, here's the evidence. We're going to give you an opportunity to talk about a pressing issue that isn't do you like your healthcare public or private? It's more than that. It's about how do we organize a workforce? How do we deal with this distribution challenge that we're having with not enough docs in rural areas? So, you'd be very surprised to see how many people that are, citizens and the general public really want to weigh in on a topic as specific as that. In terms of the lowest rated features across all of these, we're again finding that they also have trouble with us not concluding with recommendations, and another challenge at the panels with getting the right mix and diverse groups of citizens together. One of the challenges we have is recruitment of 10 to 16 participants for each panel. We're using a marketing agency now. We tried different approaches, and that seems to be the best way to do it, but sometimes you just can't anticipate cancellations at the last minute, who's reading their email on a given day when we're surveying. So we're trying to do better. It's just something that's coming out as a challenge. And importantly, we're finding that after the process, citizens are feeling as though they're leaving with something as well. So they're leaving with a better understanding of the issue or the system in general. So we're finding increases in mean knowledge ratings at the end of these processes as well. So before I move on, any questions about the key ways to get evidence about policy questions or the approaches that we take at the forum and we're increasingly seeing internationally about gaining insights? There's two key pieces before we move on to doing all this in context. Any questions or just pressing points of clarification, and we can open up a discussion in a bit. Okay, so no clarification. We'll open up for discussion. So how much does an evidence brief and an evidence dialogue cost? So that, it just depends on the topic, really depends on the topic, the amount of time. And at the end of the day, I think that if you were to email Alana Chura, who's the managing director, will have a much more accurate assessment of that. I don't want to put a number out there that's not accurate at this point. So, and we have one from McMaster. We give a small honorarium for the panel participants, but not for the stakeholder dialogue participants.
So just to clarify, the question in the room was whether participants were paid for taking part in the sessions.
Right, and we don't pay stakeholder dialogue participants, but we do provide a small honorarium for those who come to the panels.
Just a quick question about the panels with the community members. Are you going outside of the traditional buildings? Are you going out to neighborhoods and that kind of thing, or where is the location?
Mostly hotels. Yeah, I feel like a real marketing person when I'm sitting with poor choice in coffee at a Holiday Inn in Sudbury, which has happened a few times now. So it's really, we're trying to make it so if people need to travel, they have a place to stay and it's easy and they're set up for kind of a conference space, but we haven't done anything like town halls or anything like that yet. So really kind of the traditional dialogue. We try and make it as dialogue-like as possible without being, you know, in a UN type setting. So.
Kaelan, there's another question on the chat about
the intention
assessing
to use.
intent.
So I think that's probably something we can save for the discussion, because I kind of want to get through the context stuff. So great, I'll put that down as something we need to discuss. So in terms of context, evidence and insights are great. We need to do all that we can to get the best available evidence in a format that's easy to use and digest, alongside all the insights about values, preferences, constraints that might matter in addition to that evidence. But we're doing this in specific contexts. So it's really important to consider both the health system context and the political system context, two different things. So when we talk about health system context, we mean things like the building blocks of the health system. So what are the governance arrangements in a particular health system? So who can make what decisions? That matters for both how you frame a problem, because it might be about governance arrangements, but it also determines in how you frame a potential solution to that problem. So it kind of lays out the grounds for, or the rules for what you can actually do in a particular policy setting. And so it's really important to know this before you go ahead and make a particular set of options up to address a particular set of problems. So building blocks include things like governance, financial, and delivery arrangements. You also might want to consider in the health system how the building blocks are being used to provide care. And this can be done in a number of ways as well. So in Ontario, we tend to break things down by care by sector. So we have home and community, primary, specialty, which includes hospital care, all of those types of things. We also break things down by caring for select conditions in unique ways. So we treat mental health and cancer in different ways than we treat primary care. So that's the type of context, if you were working in Ontario, for example, that you would need to know about the health system. Also care using select treatments. So why is it that prescription drugs are covered for some in the province and not for others? That's another type of health system context that you'd want to know. And finally, how do we care for select populations? So Indigenous peoples in Ontario have a different landscape of healthcare options than non-Indigenous peoples. So these are the types of contexts with regards to the health system that you definitely want to know when you're trying to bring together evidence and insights to achieve impact, which is the use of evidence in the policy process. If you're not understanding this stuff right, you're probably going to frame a problem in a way that doesn't make sense and maybe even put forward options that aren't technically or politically feasible. You also want to know about reforms that have happened in the last 15 years, or it looks like you're kind of coming out of the blue in a lot of cases, as well as what assessments exist. So how are we performing across different aspects of the health system? So these are all important types of context that you would want to know about your health system in order to make all of the things you're learning from evidence and insights more relevant to that system. So we've broken it down this way. An application of this approach will be available, I think, either at the end of this month, but likely in the new year. We've written a book breaking these parts down for the Ontario system. So one application of this approach in Ontario. So you'll be able to access it freely on the McMaster Health Forum website. And ideally, it spurns others on to develop similar approaches or write similar works for different provinces. But it's one approach to unpacking this for one province. So you also want to know, in addition to the health system stuff, what are the political system constraints and facilitators that exist? What's on the screen now really is the boiled down classic political science frameworks that exist that we've drawn. So John, myself, and others working at the forum, most of us are trained in a mix of health sciences and political science. We've taken these frameworks from political science. These are the key frameworks that almost everyone uses, boiled them down to their key components so that we can think through these things when we're developing an evidence brief or convening a stakeholder dialogue. They matter a lot. So, for example, there might be institutional constraints in a particular setting, such as the structures. So you might have delegated authority for some issues, whereas it's a centralized decision-making process for others. So this is really issue-dependent as well. So, for example, if you're changing remuneration to physicians at this point, it really resides with discussions between the OMA and the Ministry of Health. You have to know that as different than negotiations of salaries for nurses, which might take place among hospital boards and nursing associations. So very different context depending on your issue. We also want to know about things like policy legacies. So why is it that we can't get around the core bargain in Ontario? So we know that physician and hospital-based services are covered, and that's kind of very difficult to move. But for some reason, even though some would argue as medically necessary, drugs have been able to go off and develop quite a robust private market. And finally, we also want to know about policy networks. So who in the province is going to wield power in negotiations with respect to a particular issue? So I mentioned the idea before of physician negotiations. They play a huge role in many different aspects of the system, in many different policy issues. So you need to know that for your context. It might not be the same in every country and every setting. So really important to understand this, in addition to the health system context. You also want to know about interest group pressure. So whether or not particular groups who are likely to raise a red flag if something goes up, if they have the type of concentrated, let's call it concentrated costs, if they're going to face concentrated costs, are they really going to mobilize in opposition to a particular issue? If it's something that is diffuse across a number of stakeholder groups, you might not have as many people raising red flags and trying to step in and stop something. These are the types of political constraints related to interest group pressure that you might need to know. In terms of ideas, what values does society hold, and what knowledge is available. You also want to know about external factors such as economic recessions, forecasts of growth. All of these things matter as much as the others as well. So really important to consider not just the health system context, but also the political system context. And you can see by me just going through a few examples how this would fundamentally change the way you write something like an evidence brief. If you're trying to take evidence, contextualize it, present a problem, options, and implementation in a particular jurisdiction, without knowing the health system and political system context, you're probably going to be speaking to nobody. You need to be speaking to your target audience, which could be policymakers, other stakeholders, could be citizens. This is the important stuff to bring together those evidence and insights. So just one example of another piece of context that might exist to support evidence-informed policymaking. So just discussed how understanding the context in terms of health and political systems might help you as a practitioner of knowledge translation figure out the best ways to frame up an issue. But there are also things that can be done to support evidence use by places like governments. So the Ontario Ministry of Health and Long-Term Care is an example that I think John uses almost everywhere. I've seen him give a talk recently because in the last 5 years, the game has just been upped to a different level that wasn't there prior to, let's say, 2010. And what's happening now at the Ministry of Health is they're sending strong messages at all levels of the ministry that evidence is an important input into the policy process. They're doing things like putting out the Health System Research Fund, which guarantees 25% of all of the funds that are allocated to researchers are held back for applied health research questions. So that just means that at any given point in time, someone sitting in the Health Workforce Planning branch might say, I need to know in the next 6 months what the best evidence is about this topic. And they'll get it because 25% of the budget through that fund is held back for that specific purpose. They're also doing things like rapid responses and literature reviews in-house. So there's a unit now that's set up in the Ministry of Health and Long-Term Care. Their entire job is to do things like rapid responses and literature reviews and prepare briefing notes based on evidence. There's also the research evidence tool that exists. So nothing that goes up to cabinet level can go up to cabinet level without having a cover letter that shows exactly where the person that writes the briefing note looked for research evidence about that topic. And there's checkboxes, and I've seen the tool. It's literally asking them, was your question about clinical program services and drugs? Did you look at access? Did you look at health systems evidence if you're dealing with a health system issue? So prompts for people in the civil service to use evidence, another strong message. There's also a number of capacity building workshops that they've committed to. So I personally go 4 times a year now to the ministry. And there's between 20 and 30 people sitting there. We give them an online course for it's about a 13-hour course that they go through, and then we spend a day with them working through how to find and use evidence effectively. So just pointing them to the right places that I've already pointed you towards, also showing them where they can go for things like user-friendly summaries, just making it easier for people working in ministries to find and use research evidence. And this is all supported by the Ontario Ministry of Health and Long-Term Care as well. And we have here as a next step, potentially, there are not many of them, but expert advisory groups. So this is something that is now being considered in the ministry in a number of different ways. John and colleagues have recently done an assessment of some of the groups that have existed over the last 10 years, and there's been 27 reports by expert advisory groups for the ministry. Most of them focus on health system and policy issues in some way or another. The average number of citations, not bad, so around 44. So I mean, it's a blunt measure of whether evidence is being used or not, but you know, let's just bear with me here. Of those citations, on average, about 1.3 reviews cited, but of the reviews cited, they're not always particularly aligned with the topic. So a recent example is an expert advisory group that was consulting on home and community care, and the citation to a review was actually about primary care. And this struck the investigators as quite strange because there are hundreds of systematic reviews about home and community care. So, you know, there's just opportunities at this point for expert advisory committees who pride themselves as being evidence-based. They're citing things to do a better job. Many of these groups didn't have methodologists, so they didn't have a systematic and transparent process for looking for the evidence, pulling it together into their reports. And very few have any citizens on the panel, so not getting any of those key insights that we know are so important from citizen groups. So putting it back out to the group, are you aware of governments that support expert advisory groups? Mostly focused on system issues, so there's lots out there, but we're focused here on those that are generally looking at system and policy issues, and do they use the best available evidence or set expectations to use evidence? So simple yes or no would be great. About 50-50, which is interesting. And we'll get into a bigger discussion because I'm interested to know about whether the expectation is that evidence is used. So we don't understand the question. So for the group that didn't understand the question, really about whether or not you're aware of expert advisory groups focusing on system issues that either use the best available evidence or send strong signals that they set expectations that evidence should be used in that process. Okay, great. So pulling this all together, we, based on what we've learned from getting evidence together, putting it in user-friendly formats, gathering insights about the same topics that we're pulling the evidence together on, as well as taking into consideration health system and political system context, we found that this is the definition that tends to resonate with us the most as people who are doing this day in, day out. So what does evidence-informed policymaking actually mean? So that gets asked a lot. There's many definitions out there. This is the one that we use. So it's about using the best available data. So that could be local data, depending on the issue, and research evidence. Systematically and transparently, that's the key thing for us, making sure that there's a process set up. You're doing it the same every time as much as possible. Tweaking, of course, depending on the issue and context. And transparently, so if you were to ask me the brief that I worked on 6 months ago, where I looked for evidence, I have a paper trail, so I would be able to pull that up. Really important for us. So not only for you to keep yourself sane as a practitioner, but also just to make sure that if anyone asks you, you have it there. In the time available in each of the priority setting stage, so when we're trying to frame problems, when you're deciding on which options are best suited to address those problems, when you're trying to figure out implementation considerations, so whether or not a chosen option makes an optimal impact at an acceptable cost. And this is all alongside the constraints we talked about, whether they be institutional, from interest group pressure, whether particular values and other sources of ideas, so those insights. And all of this influences policy, and we acknowledge that this is happening in a political system and in a particular health system. So our definition really tries to tie together evidence, insights, and context in a way that I think resonates with us, but when we put this in front of others, it resonates with them as well. So that's all I had to go through today. I'd like to leave if you can give me some access again, leave the definition up. We have some specific questions that have come in, so I'll do my best to answer them in 15 minutes. Oh, that's fine. I guess I can just I'll go forward.
And I'm just going to go back to the questions
Yeah,
that are in the
great.
chat first, and then we'll open it up to others. So the first question was about assessing intention to use, and have you done follow-up to see if the evidence or insights were actually used?
Right. So from a methods perspective, intention to use in terms of a quantitative measure is the most, well, it's the most widely used for a good reason. It's because it seems to be the theoretical framework, and the tools are available and validated to use it. But we do know that it only gets you so far. In assessing whether or not evidence and insights have actually been used is a much more difficult task. Requires what I would consider quite an involved process of doing theoretically informed case studies and multiple case studies. I did 4 of them for my thesis, and that's the only time that I've ever been able to do it. We haven't done any for the form in terms of follow-up. We have anecdotal evidence about one of our processes where we developed a brief in 7 weeks, and the insights from that went up to cabinet and was used to inform a decision about community-based specialty clinics. So that was in 2013. That's one anecdotal piece of evidence that I have. In terms of rigorously assessing this process, again, it takes involved case studies, which can cost a lot of money, take a lot of time. Like I said, I did 4 for my own thesis to try and map out the process, found that it's much more complicated than either being used or not being used. It's oftentimes in numerous different ways. So research can be used instrumentally, which is rare. Essentially you're finding a perfect match in a review form to answer a specific problem. More often than not, it's conceptual use, which is very difficult to track. You need to actually go out there and have key informant interviews, do documentary analysis, all of these types of things, compare across settings to control for things like context. So really difficult to do that. We have tried. There are methods available to do this, but what I would think is the cutting edge of this work is trying to map out how evidence is actually used in the policy process.
Okay, we have another question. How does one determine which physicians play a policy participation role?
Determine which physicians play in terms of individual physicians. So when we convene dialogues, develop briefs, usually it's at the association level. So the most recent one that we've worked on was sustainability, and it was commissioned by the Ontario Medical Association, and it wouldn't be particular physicians unless they bring to bear particular lived experience that we would want to draw on. But most of the time at our dialogues, we have representatives of physician groups rather than someone coming as an individual physician. And in our panels, we actually try and go against having individual healthcare practitioners there. So one of the exclusion criteria for selection is that they aren't a health professional, or they haven't been a health professional in the past, because we're trying to get a little bit, try to reach out a bit more to more of the general public rather than people who are intimately engaged in the health system. So I don't know if that directly answered your question, but just kind of a takeaway for you might be that we really try and focus more so on getting the stakeholder groups and representative of stakeholder groups rather than individual physicians who play a policy role.
So then there's a question about your rapid review and lit review unit and the number of requests.
So the number of people involved, so the rapid review team involves the scientific lead, which is Michael Wilson, who many people probably know as well. He works with a team of between, I would say, 3 and 5 on any given rapid response, depending on if it's a 3, 10, or 30 business day. So the 30 business day request would be much bigger and would require a bigger team. Usually a mix of master's, PhD, and undergraduate students doing varying levels of work. And I would say I said average 3 to 5. It's pretty good assessment, working around 10 hours per week on the project. So quite resource intensive in terms of the number, but I've seen it done on much, with many fewer people in different contexts. In terms of the number of requests received monthly, I think on average it's probably, if not one a month, one every 2 months at this point. It's a cost recovery, so we do ask for people to cover the costs of paying for a rapid response. And I think it's just a matter about more people knowing that we're open to doing this as a kind of contracting out service at the end of the day, because I have seen the requests increase in the last year. So if you have a specific question, I would encourage you to contact Mike directly, because he'd be more than happy to talk about it.
Okay, so we have another question about gathering information about the political system, strategies that can be used, and how long it takes.
Right, so the political system, I think there are a number of documents now available that work through the frameworks that I put on that slide, so institutional constraints, interest group pressure, and ideas. I would suggest that if you're really interested in knowing what those sources are, I could provide you with a couple of readings that are not just a description of the framework and its key mechanisms, but also an application, so a work-through application. When we do it, we kind of know the framework so well at this point that we think through it informally in a way. When we're framing an issue, we know that particular policy legacies matter, and we need to highlight that in a context section of a brief. But if you're doing it from scratch, it's a good idea to both know the framework, so do some reading about the frameworks, understand the mechanisms that are at play within each of the frameworks, and then start trying to apply them for different issues that you deal with, and eventually it just becomes second nature. But they're all rooted in those that understanding and kind of taking that lens towards things. So if you're interested, please follow up with an email, and I'll give you some resources, work through examples. There's a book, and I can think of a couple of papers as well.
And then there's a request for an example from one of the past stakeholder dialogues, some of the priority issues that have been addressed.
Right, so the most recent example that I can give of, so all of our dialogues and dialogue summaries, so the briefs and the dialogue summaries are available on the McMaster Health Forum website. So if you want to know all of the particular topics we've addressed over the 45 that we've done, then I would suggest going there first. In terms of a recent priority example, so it was about health system sustainability, and so that's one that we convened with the Ontario Medical Association. And some of the priority issues that were tackled were things like, financial sustainability seems to be the thing that dominates all the time, but sustainability is about much more than finance. So we discussed that quite a bit. Another aspect and dimension of the issue that came up quite a bit was our definition of health, which feeds into this notion of what sustainability actually means. But the fact that we have tended to focus our discussions on sustainability and costs around the traditional health care inputs that we tend to I guess, focus on the most in the province, whereas there are other things that we don't talk about as much in terms of patient and citizen behavior and how that affects things like health status, as well as the environmental factors that determine health status and affect resource use. So there's a number of different things. So a priority issue like sustainability might be taken in a number of different ways, but most recently, that's a great example of how when the dialogue happens, the discourse actually breaks down into specific themes, which is what we prepare and pull together in the dialogue summary. So again, I would really, I guess, encourage people who are interested in to see how all that comes together and what topics and priority issues were addressed within the overarching topic. Go to the website and see all the dialogue summary we've prepared, because all of them are really interesting to see how a particular issue has been broken down.
Okay, I know that we also have some questions. We're going to be going through by site. We've had great questions in the chat, but I also know that Gail's been collecting questions on her end, so maybe I'll turn it over to you, Gail, now.
Toby, do you want to go and answer questions?
Yeah, this is, I guess, referring to stakeholder dialogue. You were saying that you mentioned that it was grounded by the theory of planned behavior. Can you describe that in a bit more detail?
Right, so the theory of planned behavior is basically trying to measure intentions to act, and I think it's from psychology, and there is a tool that has been developed specifically for implementation scientists to use the theory to measure quantitatively ratings on a number of different dimensions related to intentions to act. So we add that as a part of our dialogue evaluation. So when people leave the dialogue, there's a section in our evaluation that specifically asks a number of questions related to intentions to act and the factors that might influence intentions to act, like perceived behavioral control, social norms, a lot of different things. So I don't want to get into the nitty-gritties of all of the different items. It's publicly available. I think the author on the guide to applying it for measuring KT effectiveness in a quantitative way is done by Robbie Foy. I think that's the author. But I think you can probably even just Google theory of planned behavior workbook, I think it's called, or a guide to implementation. And it's a 40-page document, hugely helpful, helps you develop questionnaires, really understand how to analyze things statistically. So which things you need to control for if you're trying to look at different domains and dimensions, as well as how to aggregate specific indicators, because the framework rests itself on the aggregation of a number of component parts. So there's a couple of aggregate indicators that are included as well. So the guide goes through everything. I would highly recommend that you look into it if you're interested in applying the theory of planned behavior.
And I have a question from OHRI that they chatted to me. So the tables you presented suggest that some of the panels conducted did not result in recommendations being made. What proportion of panels would you say this applies to? And do you have any tips on how a panel should be conducted to optimize this outcome?
Yeah, that's a really great question and difficult to answer, unfortunately, so I'm not going to give you a great answer. It's more spontaneous than anything. I think the people in the room, and depending on the day and the dynamic in the room, that's what determines whether or not people will come to terms about what actions need to be taken and whether actual actions are taken. So again, we don't try and facilitate that. Sometimes it's just the mix of people in the room and the topic. In terms of proportion of dialogues that have actually resulted in concrete things happening immediately or shortly thereafter, it's tough to say. So I guess it depends on what you consider impact, because some of them have resulted in the creation of a working group that, you know, goes behind closed doors for months and months and months and months until the issue gets on the governmental agenda again, and then they take action, and it looks very different than what they had originally decided on at the day of the dialogue. So another thing to realize with this entire process is when you're viewing it, measuring it, trying to figure out if things are having an influence, things change over time and evolve over time as well. So the insights and next steps that are developed at the end of a dialogue might look completely different as time goes on into the future. So I know that's not a great answer. It's very difficult to assess specifically. We, again, stand by our rule of not trying to aim for consensus. So we don't even think about how we're going to get it out of people, because that was part of your question as well. The reality is it's just a fortuitous event. You get the right people in the room on the right topics, and people who are willing to be constructive and think through things and try and work together for collective action. So I think it's really about getting the right people in the room. One thing I would recommend, though, if you're considering convening a dialogue, so writing a brief and convening a dialogue around the brief, is when you're doing your assessment of who should be in the room, that's your moment where you might be able to influence this a little bit. And what I mean by that is you need to choose people who aren't going to be the curmudgeon in the corner and aren't going to be willing to work with people that they, on paper, should have, you know, very differing interests with. So over time, the forum has developed a relationship with a number of different organizations and groups and realized that there are specific people representing those different groups that are just great at kind of putting their own interests and their own values and opinions forward, but also willing to listen to others. So it's about being constructive and willing to solve problems collectively, realizing that you might have different opinions than others. So I think that if there was an intervention or place to intervene, it would be early on in the process when you're deciding who you invite to the dialogue, to try and aim for fair representation, but just making sure you have constructive people that are, I guess you can do rather than can't do type people, and you're probably increasing the likelihood that you're going to, you know, get that magical mix of people in the room that are hopefully going to work towards some sort of action.
In the interest of time and scale here, I do think we have to end. Is it okay if anyone has any extra questions, if they email them to me directly and I send them to you?
Sure.
Okay, great. So if anyone didn't get a question answered, please send me an email. I do have one chat that I will address via email as well, so don't worry, Anna. And I'm just going to thank everyone for attending today. It was a very interesting presentation, and the next session will be January 12th with Sophie Devosh, and happy holidays, everyone.
Okay, thanks everyone, and I just want to also remind you to email Gail your evaluation forms, please.